classified as potentially requiring. And you basically go to the FDA and you say, we have this capability, here's the AI we're trying to do. And most of you probably don't know this, but there have been just under 200, soft 200, not 20, not 200 software as a medical device components cleared by the FDA over the last several years. We're not making this up. You just go to the FDA site, you look on the list, and software as a medical device, which is AI with lots of AI components, are being cleared today, right? So this idea that somehow it's not possible, regulatory impediments are in place, and none of that is true. The only impediments are us in this room, right? Us saying to each other, you can't do this and you can't do that, right? So that's why it'd be great to have this conversation with a prelude to say, if we're going to do some advanced stuff, what do we recommend? And then pulling in the audience questions here and there as well. So Robert, I'll let you go first. Introduce yourself and what you do today. And you just recently had a change in position as well, so you can tell us about that. And then we'll do the same with Yair, and then we'll jump into questions.
Well, good afternoon. We've got that coveted post-lunch spot. We're looking forward to getting everybody revved up for the rest of the afternoon. My name is Robert Groves. I'm a physician, critical care doc by training. Been in practice one kind or another for a few decades now, and recently left my position on December 31st as the Executive Vice President and Chief Medical Officer of Banner Aetna, which, just like it sounds, and yes, there was a focus group to come up with that name, is a joint venture between Banner and Aetna. So a delivery system, about a $12 billion plus dollar delivery system based in Phoenix, Arizona, and Aetna you'll recognize as the insurance company. Since leaving that role, I am doing some independent consulting now. I'm working with a company called Risk Averse. I'm beginning to work with a company called Care Cognitics, and there will be others along the way, I'm sure. All of these engagements that I'm involved in now are related to AI. And the first thing I wanted to do is comment on something you said about replacing humans. And I think that rather than thinking of it as an either or, it has gotten to the point now with the advances in medical knowledge alone, we need AI support in order to manage that. Knowledge management has become a thing. You know, in 1950, it took several decades for medical knowledge to double. Now it's measured in months, if not less. And keeping track of all that and understanding what the newest developments are in any field, I don't care if you're a specialist in oncology or nephrology, you can't keep up with it. It's not possible for human beings to do that anymore. So just in terms of knowledge management, it is necessary for us to embrace technology to help us stay abreast of that.
Good afternoon, everybody. My name is Yair Saperstein, and I am the CEO and co-founder of a company called AVO. By background, I am a hospitalist and clinical informatician, so dual board certified, coming from the perspective of a practicing clinician, actually as a per diem hospitalist in Mount Sinai, Beth Israel, and Mount Sinai, South Nassau. But when I started AVO in 2018, the primary reason that I started AVO was exactly as you said. There is way too much info for me to keep track of, but I wanted to accomplish a couple of other things. One, get me home in time to have dinner with my family and allow me to swim in the ocean. I'm a free water swimmer, like to surf. It's like I didn't want to be stuck in the hospital. At the same time, I didn't want to be just in the water. I wanted to also be a good doc, a good clinician. Let me actually serve my patients well. Let me do the things that I need to do well. And in order to do that, it wasn't just the information overload. There's all of these tasks that I needed to do. So somehow I wanted both clinician support, allow me to actually be a whole person, and clinical decision support, allow me to be a good doc, a good clinician at the same time. And everything that existed was either one or the other. So now AVO as a company is a suite of clinical AI tools. So think AI Scribe, AI Chart Review, and compare to the guidelines to tell you here's your pre-visit synopsis and things that you might want to do, an AI Consult, but not just as point solutions, really as a platform. And the way that I think about this question of AI and solving these problems where there's not enough of a workforce is a little bit different. I think we're in this like AI bubble in a way that people think that AI will be able to do everything. It's like agentic systems now can solve everything. And I've always thought about it as with human in the loop and the ability to take away the tasks that are pointless so that we can have more of humanity back in what we are doing, we suddenly have a way of efficiency. And it's not just, okay, let's throw everything into a large language model and hope for the best, or, information overload. And so we need LLMs to be able to solve that. I think that there is a way of having rule-based logic, right? Decision pathways coupled with data extraction from the EHR, coupled with a knowledge base from societies or insurance providers or wherever that or even individual enterprises, and put that together in a way that structures LLMs and rule-based logic that is controlled in the back end by a system, maybe some off the shelf, and then allowing for the user to have an overview so that the user, the human, is the one in charge. Suddenly you have efficiency so that you can have yourself as a human, and then also correctness, right? You can actually do things well as clinical decision support. So this is how we often think about it, how I have long thought about it in our way of augmenting humans by allowing for AI, but also everything else in solving problems.
Yeah, and as we brainstorm up here, remember, you guys can ask questions. One thing I wanted to present is maybe we're all doing ourselves a disservice by just using the two letters A and I together, when really we don't have to. And I was just having a conversation during lunch, reminding myself that many, many years ago, I had the privilege of leading the technology team for the Alaris infusion pump. How many of you know what an infusion pump is? Certainly all the nurses do, because it's for many, many years I've worked with nurses on like that and the Pyxis Med Station and a bunch of other things that we just, we just take for granted. It's just, of course, we have an infusion pump that's fully automated and can get a prescription from an EHR into the infusion pump, and it can make sure that the human doesn't get overdosed and that the boluses are all correct. Now, if you think about every step here, if we were, when we were building this back in the early 2000s, we could have used the term AI and it would have scared the crap out of everybody, right? Which is what we're doing today. If you put the word AI in front of anything, if I said this is an AI-based infusion pump, it would scare the crap out of you. But we use this for decades. Now let's remove the word AI and just call it an automated infusion pump. Now, what happened to our fear? It's gone, right? Now, how many of you have seen an AID, like a automated insulin delivery vehicle that that type 1 diabetics often wear? Have you anybody seen one before? That thing is like freaking magic, right? But if you said it's an AI automated insulin delivery pump, scares the crap out of everybody. But if not, people use it. What do we do with this term? To me, it just seems like if you don't know how to describe it, you say AI. But if you know how to describe it, you say automated, right? Is that a reasonable statement? And please, others jump in as well. Robert, go ahead.
Yeah, it's interesting. Before I get to that question, and I apologize for deviating for a second.
No.
I want to double down on something Yair was talking about, which is the human aspect of medicine. And we all are aware of the existential risk associated with AI, which makes us fearful. We're all aware of the risk of cybersecurity, privacy. All of those things get talked about a lot. What we don't talk about a lot, that I think is also a major risk and also a foundational risk for physician and caregiver burnout, is if we use AI simply to increase productivity such that a doctor, instead of seeing 20 patients in an afternoon, can now see 40, we have missed the boat. Because the foundational principle of health and improving care is the relationship, that therapeutic relationship between physician and patient that we've sort of seen pushed to the wayside over time. And unless we talk about it, I guarantee you what we're going to see is productivity, productivity, productivity without giving time back to the therapeutic relationship. And I think that is a key aspect of what we need to be doing to address physician burnout, to bring meaning and purpose back to the practice of medicine, and to really take advantage of this opportunity. We have to talk about this. I want everybody thinking about that as you go back to your organizations. How are we going to use this to support the therapeutic relationship? And remember, the placebo effect is incredibly powerful. It is not nothing. It is, in fact, so powerful that we use it in every study that we do. We don't compare against nothing. We compare against placebo for a reason. How do you get a placebo effect? Well, the shorthand for it is you need a shaman and a belief and a ritual. Well, you know what? That therapeutic relationship meets that bar. So it's not just that we have incredible advances in technology and intervention over the last several decades that I've been in practice. It's also reigniting that therapeutic relationship between patient and caregiver that fuels the placebo effect, that makes people want to live. They have a reason, they have a purpose, not least of which it gives that physician purpose and meaning. That's why I got into medicine, and that's what we need to get back to.
So we accidentally gave Robert a lapel mic instead of a real mic. But that was a mic drop moment. So Yair, so definitely build on what Robert is talking about, especially the practice of medicine part. And I'm actually surprised, in a good way, that Robert made the following assertion, which is, "You just made me more productive, but that's actually worse for me as a doctor." Remember that statement? Yeah. And now build on that.
So a couple different points. One, to build on that is, productivity is important for a system, right? When you're looking from the C-suite level as a system on these different tools, you are looking for an ROI. And if the tools don't provide an ROI, it's not going to be worth it after a year, right? So you are always looking for that productivity. If that productivity comes at the expense of the people that are working, that's the problem. But I don't think that the problem is productivity. And that's why it's, for us at AVO, and I think a lot of the groups that started as AI Scribe and are coming more to the middle, or the ones that started as a broader platform like us and are encompassing, right? Or the ones that started as Chart Review and are coming into the middle, wherever it is that you're starting, you're thinking about the hard ROI. Can you do CDI in addition? Can you do risk adjustment in addition? Like, what are the places that can bring systems more money, that can justify the cost, in addition to being the human support, right? In addition to being the clinician support. So I do think that there is a level, but it depends on the stakeholder, and you have to really balance the two stakeholders, both as a system and as a vendor. I also really liked your question about the use of the term AI, and I disagree. So you were saying, if you don't know what a system does, then you call it AI, and if you do know what a system does, then you call it automated. We had a marketing meeting at the start of, I guess, early 24, maybe end of 23, where we were trying to figure out, do we want to use the term AI or not? And our conclusion as a company was that we didn't want to. It wasn't, why should we use the term AI, instead of describing what we actually do and how we actually solve systems. And over the course of the year, if you use the term AI, suddenly you had eyeballs on you. And if you didn't, then you didn't have eyeballs on you. And we decided to use the term AI to describe the fact that we did have AI components in our system, even though we were previously describing ourselves with just the functionality. There's a difference between marketing and what you actually do, right? And so, like, yes, we are marketing with AI, but the problems that we're solving are workflow problems. And how can you have a more efficient workflow, and how can you be more automated with solving the ROI issues, right? So there's a difference when you get down into the details, but we do use the term AI in order to allow for eyeballs.
Yeah, and that says something about us as buyers, right? So if you think about people who buy things, that says more about them than it does about what you're doing, right? Because if the eyeballs only come because of hype, well, then of course we're all going to use hype, and in fact, that's where hyperbole comes from, is hype, and we're hyping it up, making it hyperbolic, so that people pay attention to us. And it was the question is mostly rhetorical, because we can't not say the word AI. You have to say it. But really, as you're describing it, especially, there was a very good question asked in the previous session about how do you engage and tell your bosses about this? So for sure, as vendors and partners, et cetera, we have to use the word AI, maybe to differentiate, et cetera. But internally, when we're talking and pitching a project to our bosses, should we use that term, right? do we need to use that term? If the answer is yes, because even in an internal project, you have to get eyeballs, well, then of course you have to do that. But it's possible that because we're using that term, we're doing a disservice by not focusing on the outcome rather than the vehicle that we use to obtain the outcome. So, and I thought there was, did somebody I thought I saw a hand raised here somewhere. Was there? No? Oh, you had one? Yeah.
Your and the placebo effect of helping patients feeling understanding that you're there for them really goes a long way. And I'm a practicing pediatrician for many years now, and I'm independent still, which is a rare thing. And I'm doing very well with having a very busy, packed day. People call, I get them in. So you say, well, am I very tired? Am I very burnt out? I would tell you no, because I really enjoy what I do. Nobody's knocking on my door and saying, go quickly. I'm there and I understand the productivity part. We have to make money. But I feel if you give that time to every patient, that's why they're there. It brings you money. It brings you lots of money, and you do very well for yourself. But that placebo effect is extremely important.
And how do you drive that placebo effect using, let's say, more modern AI tools that have become available in the last few years?
Yeah, well, I think that the goal is to automate menial tasks, right? And so there's a huge opportunity to take care of back office stuff. There's a huge opportunity to take care of those menial and with very little risk because you're not too worried about the diagnosis and confabulation, et cetera. And so that's step one. And you know, ideally, it becomes like an agent that can be a support for you that you could just say, would you help me, you know, find the last 3 notes on this patient, or, you know, having a real agent that can help you do those things. I think that's ideal. And I think we'll get there. I don't know how long it will take us to get there. I think Janae said never. I don't believe that. I think it'll
Could be by the end of this week.
Probably not by the end of this week. And then I think that the second way that you do that is by the things that Yair and I were talking about earlier, is that so if I have an AI backup, let's say, or an augmented intelligence that allows me to, well, first of all, AI can do a thorough and complete history because it knows what questions to ask. And so if you get that piece of information in front of you from the get-go, that would be useful. Now, I also think, and this is the way that most academic programs work, it's great to have a medical student to collect that rote history, but the attending needs to come in and get the nuance, and you know, and that's what the human aspect of this is. Then the second part is differential diagnosis. It can be hard to remember everything that might be represented by this cluster of signs and symptoms. So having a reminder, a nudge that helps you do that can be very, very useful. Maybe it's not a final diagnosis. That's something that I still would reserve for human beings. And even recommended therapy. Again, knowledge management. What would you do in this circumstance? And then again, validated by a human at this stage of the game, I think is an important aspect of it. But if you do those 3 things, then it does give you time back to have that intimate conversation with another human being to discover, number one, what's important to them. Sometimes it's difficult to get that out of a rote history, if you will, and it takes some nuanced question asking, et cetera. And number 2, the establishment of trust. It's hard to establish trust in 6 minutes, which is, you know, the average time that a physician is spending with a patient face to face right now, often looking at a computer screen. That's not an easy way to establish trust. So if you can get that rote stuff out of the way, the simplified stuff, put the reminders up there, then you have an opportunity to develop a relationship that, you know, and trust is a part of it.
Yeah, that makes sense to me. So Yair, since you guys are formed pre-generative AI, what does the world look like from your technology stack as well as utilization of generative AI versus just what you were using before and now are labeling AI? And machine language is real AI. I mean, sorry, machine learning is real AI. So it's not like, knowledge bases are real AI. But what are you using post-generative era versus pre-generative era?
So one comment first, which is if you're going to give me a nudge of what I need to do, as long as it won't appear as often as you tell me to give a flu shot, or the other best practice alerts that I just dismissed without reading, so I can't even tell you what they say, maybe it'll be okay. But otherwise, I'm not sure if I want that nudge because it'll take away from the interaction. I might prefer more automation. The way that I think about like what we can do with generative AI is, of course, first is the menial tasks, right? And that's already there. Right, even the writing a note, the AI scribe, chart review functions are getting there, but the agentic systems leading towards differentials and then being able to put differentials into, let's give you an order panel of what you might want, right? Each of these next steps is what comes next, and we're starting to do that with AI Consult inside of Epic, Meditech, Athena.
What scares you when you use generative AI now?
So what scares me is if you put it into the hands of patients where we are now, right? So I would put it into the hands of clinicians because when I see suggestions, if there's something that makes sense to me, it makes sense. If you put it into the hands of an APP or mid-level that perhaps doesn't have quite the same experience level or training level, then I want it to be more rule-based logic rather than AI logic, and then it works great. We have studies on that from the pre-AI era of our company. But then if you think about putting into patient hands where we are right now in a system like this, where there is no gut check that you can do from your previous knowledge, that's a little bit scarier.
So and I'll get Spencer's question in 1 second, but you said that you wouldn't want to put this in front of the patients, but the patients would not be coming to you. They're already putting this stuff into ChatGPT. So what would you do in that case from a training perspective? Would you say, let's say, for example, she's a physician, what should she tell her patients? Don't use ChatGPT? Or what would you recommend?
If the patients are coming to you, right, then they're clearly coming to you for a reason rather than using ChatGPT. And will we get eventually to a rule-based system coupled with LLM system that can work for patients? Maybe, but we're not there, right? And I think sometimes about like, here's a story. Back in this marketing meeting, when we were talking about AI, one of the questions that we posed to the company is, if Avo were a car, what car would it be? And Tesla, Waymo, my co-founder, head of product and engineering wrote rocket ship. Just shows you what kind of visionary he is versus the rest of us. So, but the difference between Tesla and Waymo is Tesla, it's pretty good for going everywhere, but you still need somebody in the driver's seat. Waymo you can trust on its own, but it's only in that select area. Waymo is almost like an AI plus rule-based system that then you could trust within that section. Right, I get it. But if you're trying to make it more broad, you still need somebody in the driver's seat now. Otherwise, it's going to lead to problems. Will it still provide its benefits in different areas? Can you allow for more of a liberal view of it versus the conservative view? Sure, but then it's going to end up backfiring when it does something wrong, and that's where regulations come into play, right? You don't want to go there to cause problems. You take new innovations a little bit slower, but put it into places where it can help now. So like for docs, for clinicians, to answer your question directly about the progression of Avo and where we saw results, like we first started as a pathway-based system. So it's a back end where you can basically put in your pathways in a way that's customizable for systems. And we showed that we can improve, like basically up level, mid-level APPs and the like to be able to practice extremely well, such that results are better than they were before replacing, right, the force with the not as well trained or experienced as if you would just throw a doc into there to be able to work. And so we were able to show those kinds of results, which allowed for systems to have a bottom line that was improved and patients to actually get better care. Once we were like taking a look at the results and we were like, well, pathways are great for APPs and anyone that might want more of a prescriptive pathway, but docs never use it. Right, so it's not helpful. It's great that your pathway can generate orders. It's great that your pathway can even like generate notes for you, but it doesn't help if docs aren't going to use it. So it's like, well, what do docs want? Help me write the note automatically, but from listening to the conversation, do my billing automatically, do my orders automatically in a way that I can review and then go forward. And so it's like, okay, we have a suite that's built out for each of the respective sides.
That's a good progression. Go ahead.
space. It took like less
Do you mind standing up? I don't think you guys, can you hear him? All right,
Yeah.
thank you. Go ahead.
Hey, I'm Cyrus. Good to meet you both. Thinking about the AI scribe space, it took less than 18 months for it to completely commoditize, going from Nabla and a bridge to now there's 30 different vendors, and it's not a lot of differentiation. And then thinking about more ML powered OS that aren't going to just do scribing. Commuter is buying them all up. I don't know what's going on there, but it seems like there's also that commoditization trend. So what's the differentiation? How do you make sure your solution is positioned in a way that it's not just going to get bought up or replaced by something Epic grows itself?
So what I heard was there were a couple of AI scribes. Now there's 30 plus AI scribes that people know about, and probably 150 plus others that people don't know about or have never heard. And or Epic has this kind of stuff that they're either working on outwardly or stealthily, whatever it is. Everyone knows that these things are going to come, and the AI scribe market is commoditized. So how do vendors differentiate themselves? Yeah, I think there's like two primary ways. One is platform, right? So systems prefer to have a platform that can cover more than one thing, and not just systems, like the providers, clinicians, docs want the ability to have a system that's not just going to do your notes, but also do your billing. And if it's going to do your notes and not do your billing, and you have to spend more time on your billing than you would otherwise, it's not helpful, because it doesn't really save you time. You just need to learn a new workflow. So I think there's an interest in more of this platform play. Give me a true AI assistant, not just a point solution, and let that AI assistant tie into ROI, solve a real problem for me with a specific workflow. A second thing is, I think simply price. Like, as AI scribes become more commoditized, the cheaper that you can get the same exact solution for, the better from a system side. And so even if you spent a long time investigating one of these larger big three names that are now 4, 5, 6 times the price of another one that has proven to be the same, why wouldn't you switch to one of these that, especially if it has a platform play of where it can be? And then I think the gorilla in the room is, of course, Epic. And the question is, do you wait for Epic to do this kind of stuff on your own, or do you do it? And it depends on the ROI. If you're going to get ROI in the next couple of years, 3, 4 years before Epic gets to it, even a year, is it worth it for your system to just sit back and wait? Or are you going to lose your docs to other systems? Are you going to suffer from not getting the ROI of whatever these systems are, whatever the vendors are providing, versus what Epic might do? If Epic has it already, it's a different question, right? It's like, are they charging that much more versus what the vendors are? Is the functionality the same? Does it work as well as a platform? Is it as customizable, dependent on what the needs are of the system?
Great. Did that answer your question, Cyrus? Yeah. And was there another question? Okay. Did I miss one? Okay. So the next question for me is that as you look at the next up above one level from scribes and ambient AI, et cetera, the higher level clinical integration knowledge bases require a level of data integration that is probably well beyond what most hospitals, health systems are doing today. From both of you, based on what you're seeing, maybe even at the payer level or just at Banner where you just left, Robert, what was the state of data integration in terms of just regular reporting and dashboards and those, quote, old-time analytics versus the more advanced things that you would need to do the next generation AI?
Yeah, great question, because it remains a major problem. And from the payer perspective, the way that the expectations of us, the public, with regards to payer is that all comers are valid, right? And so, yes, Banner Aetna has they call it performance network, read narrow network. And then it's a clinically integrated network, essentially. And there is a platform to help capture data that is rolled out to the independent docs that are part of that clinically integrated network, but it's not perfect, and it doesn't capture everything the way, Banner is a Cerner shop, the way Cerner does. And then there's the Banner employed docs. But outside of that, you have the broader network where there may be no contracts. They're not part of the clinically integrated network. And then all bets are off as to what system they're using. And the last time we looked, there were at least 30 different EMRs across the clinically integrated network. I think that'll narrow down over time, but right now it is still a major problem to capture all of that information. What payers have, and they do a great job of capturing and using, is billing data, but that's it. I mean, that's what they get on a regular basis. Now with Banner Aetna, that was integrated with Banner data, and to some extent clinically integrated network data, but there's still a large chunk of the population that's outside of those walls. And for example, if you're talking about Banner specific docs, they were only responsible for seeing about 20% of the patients that we covered in Banner Aetna. So there's a huge, and now more of those in the clinically integrated network, close to 50%, but that still leaves 50% with essentially no direct data integration for clinical data.
Yeah, and to make matters worse, this is a fairly disciplined, sophisticated joint venture between a $12 billion with a B dollar health system and a multi-$100 billion company on the health plan side, Aetna. And this is their story. Can you imagine what everyone else's story here is? So when we look at AI, and we look at the kind of stuff that Yair is talking about, everybody should be doing scribes, ambient AI, whatever you can today, just jump in. Doesn't actually matter what vendor you choose today, because 5 years from now, it's going to be slightly different. Whoever your vendor is today is going to get bought by somebody else 5 years from now. Don't worry about it. Jump in. Why? Because your workforce doesn't know how to use ambient today. Your workforce doesn't know how to use scribes today. So that's the big pitch. Start using it as fast as you can. The second thing is where it needs to become useful is that we've had for many decades now this data integration problem, which culminated in dashboards being empty, unused for obvious reasons. But like if I was a CIO and somebody came to me with an AI idea, I'd say, I'm happy to put that in once we get our data integrated. That shuts down all conversations, right? That's why if you're going to bring an idea to a CIO or a CMIO or somebody else, try to pitch it as to something that can be self-service capable. So it's too much to say, let us use ChatGPT, because they're going to be afraid of it for no reason, but they're going to be afraid of it. So no CIO in their right mind is going to say, oh yeah, let's broadly roll out ChatGPT tomorrow morning. But it does mean you can start to scout what is self-service in nature and bring that in, right? And that's kind of like the stuff that you guys build is, you don't need the entire organization to switch over and use what you're doing in order to start to benefit from it. So talk about that as what's a good way to introduce the next level up in AI with self-service or edge, not edge in the sense of local versus remote, but periphery, right? Bring AI into the periphery before you try to get, enterprise-wide, et cetera, adoption. What are your suggestions there in the last few minutes that we have?
Yeah, so on interoperability, right, FHIR standards, Fast Health Interoperability Resources, like the next level of HL7, allows for much better interoperability than we had. That doesn't solve the problem of we have 30 different EHRs unless you have your own HIE or you feed into the HIE, which is happening. So I think over the next 5 years or so, which sounds like a long time in the post LLM AI world, but it's not that long relative to the decades that we've waited, this problem will be solved, right? We'll have the ability to integrate. AVO pulls in records via FHIR, meaning we're able to read lab data, vitals, notes. We have a data extractor layer, so we're able to turn that into Boolean logic to go down rule-based logic, or feed that into a GPT box and then, use LLMs to be able to interpret it, do AI agents on it in a way that can either be preset or that you can ask whatever questions you want, or that can tie into your ambient listening and then combine it with the HR data and process it that way, right? So you have that customizability already. This is out. We're doing it. The question is, can we do it with every EHR that's out there? No, but does it provide enough value now to start working within these different systems? Yes, right? And so that's the point. And I think it's not just AI scribes. Like I was having a chat with someone before on the research side. Like, is there the ability to use this for research to look back at cases that are a quality concern to be able to do chart review within this context. And can you set your prompts of what you want it to be able to read that? And the answer is, of course, right? You can customize these tools for any way that you want. Cyrus, to be able to add in 2 points to you, which I think ties in directly. Before systems are going to start experimenting with these tools, right? If you haven't already, number one, make sure that there's the right security. So look for a minimum of SOC 2 Type 2 security for these tools. This way, there's not just HIPAA protection, but there's also security level, right, for breaches. The second is you want something which is EHR integrated, but EHR integrated with some form of interoperability. So if you're going to be using these kinds of tools, make sure that there is the ability to actually pull out the EHR data, to write back to the EHR for your relevant EHRs is a way to start so that you can start to experiment with chart review, comparing to guidelines, AI consult, AI scribe, wherever it is that you want to start with whatever subsection if you haven't already.
That was a fantastic way to end it because he ended it right, like literally exactly on time. So that's great. With that, big round of applause for this panel.